And hello and welcome along. Hi, this is Kathy Frey from IMCO, from the International Integrated Maternity Healthcare Organisation, and welcome along to this week's live webinar, our Maternity Natural, part of our Maternity Natural Health series. And I want to say a big hello today and welcome along to Dr. Michelle Duran from Florida. So say hello, Michelle.
Good morning and good evening from where I'm from. Nice to be with you all today. I'm so excited and honored to be with you all to discuss this very important topic on gestational diabetes.
Yeah, it's just like an epidemic going on, isn't it? So look, just to give a bit of overview of Dr. Michelle Duran's background, is that she's a pregnancy blogger and has a background in health as a family nurse practitioner, but particularly as a diabetes specialist. So type 1, type 2, and type 3, which is gestational diabetes. So all around that, which is a big deal to sort of understand it from all of those perspectives. And she's a childbirth educator with quite a passion of anything to do with woman, and she'll tell you more about herself. Michelle holds over 10 health and wellness certificates, certifications, I should say, in lifestyle medicine, nutrition, aromatherapy, health coaching, and mind-body medicine. So really that whole holistic stance, which we love here at IMCO. And she's also creator of the Sugar Bump blog, which is where women with gestational diabetes can get recipe ideas and inspire their menu planning and manage their blood glucose. So that really, yeah, she'll tell you more about her Sugar Bump blog. Michelle also creates digital products and nutrition courses that help women sort of navigate that whole pregnancy and gestational diabetes, because around 50% of women, you might have a more up-to-date status on that, but it's generally around 50% of women that get gestational diabetes have no apparent risk factors for it. So often women who know that they have some risk factors, such as having a high BMI, they are kind of aware of their risk factors sometimes. But for those women who it's the last thing they think is going to happen to them, and often it becomes as shocking and concerning and worrying, and it's just, it really impacts them at a very emotional, anxious, stressful, fearful sort of level. But we're going to really go over that understanding of gestational diabetes nutrition today. So do you want to just and also, if anybody has any questions, just a reminder that you've got a Q&A button down the bottom there if you've got any questions for Michelle. So I'm going to hand it over to you, Michelle, and let you introduce yourself better and explain more about your specialist topic.
Okay, thank you so much, Kathy. And again, thank you for having me. I am Dr. Michelle Duran. I am out of South Florida. I live in Broward County, not too far from South Beach. Some people are probably more familiar with that tourist area. And I've been a nurse and nurse practitioner for over 15 years. I started my career in pediatrics, always had a love for women's health. And so being a family nurse practitioner really left that door open for me to work with women. And I'm transitioning my career now into fully being a women's health nurse practitioner, where I'm working more with women with gestational diabetes and those that are at risk for gestational diabetes. This opportunity came from me actually being able to work with a lot of women during the childbearing period. When I was in endocrinology, I saw women with gestational diabetes, women with type 1 and type 2 diabetes that were trying to conceive, and just seeing the gap in care. I wanted to learn more about it and I wanted to be able to kind of meet that gap. And so I changed my specialty from just being, I guess, a general family nurse practitioner working in internal medicine and family medicine and going full on into women's health. And so
fantastic. And it's, you know, it's not you. It's a little unusual to be a nurse who is also a doctor, has a doctorate, and you know, good on you. That would not have been, you know, that's no easy slide in.
thank
Yeah. What is so? Tell us, what is that sort of formal definition for you of someone with a sugar bump? I love how you've kind of coined that phrase, a sugar bump. So tell us more about that.
So it's actually funny how I came up with the name Sugar Bump. So, you know, I'm on Facebook and I'm hanging out in these gestational diabetes Facebook groups because I'm trying to learn more about my ideal client and their pain points and where women and parents really need help with managing their gestational diabetes. So you hear the term over and over that I had my sugar baby today. And so that's the term that the women with gestational diabetes would use for their babies. They would call them a sugar baby. And so I told my husband that, you know, I want to call my business Sugar Baby, a sugar baby coach. And so he says to me, do you know what a sugar baby is? And, you know, really, as a clinician, your mind is far away from that. I'm not thinking about, I guess, the common definition of what a sugar baby is, and so, you know, to make sure that I'm attracting the ideal client that I want to attract, which is women and parents with gestational diabetes, I changed it to something more subtle, called Sugar Bump Coach. And so, Sugar Bump Coach then is any type of woman that has hyperglycemia in pregnancy. So hyperglycemia in pregnancy has traditionally been defined as anybody with any type of hyperglycemia, meaning that they may have prediabetes, they may come into pregnancy having undiagnosed type 1 or type 2 diabetes. So they've been living with diabetes, but they just didn't realize it until they have that first prenatal visit, because unfortunately, some women do get lost to care. They're not getting regular primary care. And so they come into pregnancy with the undiagnosed type 1 or type 2 diabetes. And then you have women that may not meet criteria for prediabetes, but their blood sugars are still elevated. And we know from research, even if you don't have a diagnosis of gestational diabetes, or you don't meet the diagnostic criteria for type 1 or type 2 diabetes, just having that elevated blood glucose still can impact pregnancy outcomes. And so they fall into that category as well. And then you have the majority of people that are going to be diagnosed with diabetes, gestational diabetes, which is what the ADA in the United States, the American Diabetes Association, defines as diabetes diagnosed in the second or third trimester of pregnancy that was not overtly was not overtly type 1 or type 2 before. And so anybody that falls under that umbrella has a sugar bump.
Right. And for those, I mean, most of our audience tends to be birth practitioners and maternity natural health clinicians of all various modalities, but we also have mums to be that watch these webinars who don't come from a healthcare background. So in a really simple summary, could we say that type 1 diabetes is something that tends to be diagnosed in childhood or teenage years, and this is a sort of a malfunction of things, and it's not really that person's fault. It's not lifestyle related. It's just something that's within their physiology of their pancreas. And then type 2 is that one that's more lifestyle impacted or created from that lifestyle, and often is diagnosed as adults and older adults. And then the type 3 gestational diabetes is when a woman become temporarily diabetic through as part of their pregnancy. And generally, you know, I might be oversimplifying and you might have a way better definition, but when you're pregnant, you sort of naturally, physiologically, as part of your pregnancy, become a little insulin resistant. And so your pancreas needs to produce more insulin than it normally would do in a non-pregnant you. And some women's pancreases just can't keep up. So their body ends up becoming having gestational diabetes. So that kind of is broadly explaining those three different ones.
Yeah, I definitely agree with those definitions. I would say, though, about type 1 diabetes that it traditionally was a disease that was diagnosed more so in childhood and adolescence, but now we're seeing it diagnosed even more in adults because you have latent autoimmune diabetes. And so we're seeing that patients are actually developing type 1 diabetes really slowly over time. They have markers for autoimmune disease. And over time, we're seeing that the autoimmunity is destroying their beta cells, their pancreatic beta cells, and they eventually become type 1. And this could be even into the 6th decade of life. So you can be 60 years old and be diagnosed with type 1 diabetes. And so,
Gosh.
yeah. And so we really don't know what's causing it. Type 2 diabetes, we know for sure, is very complicated and there's multiple factors involved. Lifestyle is definitely one of those factors. But lifestyle, we're finding, is also a factor in some autoimmune disorders. Maybe not the same lifestyle factors in terms of sedentary lifestyle or poor diet, but it could be the toxins in the environment that are triggering these autoimmune disorders. And so we're starting to see even more autoimmune disease in the United States. And one of those autoimmune diseases on the rise, unfortunately, is type 1.
Okay. That's,
Yeah.
wow. Okay. Just getting worse. So what, obviously when women do get pregnant and have developed gestational diabetes, obviously as a midwife, I've dealt with lots of women in that situation, as so many of us can't help but have. So I would try and explain to them that the in a simplified way, but an accurate way, that those, so long as they could manage to keep their blood sugars in normal range, then it has not a lot of impact on the baby. It's when the woman's blood sugar levels are not able to be kept in range that's when it will impact the baby. But going back to the beginning of the pregnancy, I know myself, I would always do an HbA1c with every woman in booking bloods, because as you say, so often when women are pregnant for the first time, there's a bunch of things that we can end up discovering that they had no idea about. Oftentimes, and not necessarily from lack of general medical care. Sometimes it's just they've never had symptoms, they've never had any need, or things like maybe, quite often their pregnancy ultrasound is their very first ultrasound. So, this is the first time anybody's looked inside and discovered, oh my goodness, you only have one kidney. And they've never known that. Nobody's ever known that. I've had that happen a few times. So sort of those sorts of things. But what's your thoughts on the HbA1c as a standard thing that we should all be doing with every newly pregnant woman, rather than just doing it for those who are high risk? What's your thoughts on that?
So I think there's pros and cons to doing universal screenings. I mean, if you're doing universal screenings, expect to have more false positives. So here in the United States, the American Diabetes Association says there's 3 different tests that you can use to diagnose undiagnosed type 1 and type 2 diabetes in the first trimester. And the hemoglobin A1C is one of those tests, along with the fasting blood sugar, and you can also do an oral glucose tolerance test. They do say they don't want you to use the hemoglobin A1C to screen for gestational diabetes after the 15th week of pregnancy because it's not accurate. So it has to be done early.
Yeah,
You can't
so it
use
really has to be that first trimester. That's the whole thing. Yeah.
And even the hemoglobin A1C, because your blood volume changes so much during pregnancy, you're so hemodiluted, it might not be as an accurate test as you would hope for. And so
as
maybe
long as it's done in that sort of first half of that first trimester, then it's reasonably accurate, or?
I believe it is.
Yeah.
I think I like to look at different types of tests just because the hemoglobin A1C is an average of your blood glucose, so you won't know where somebody's getting spikes. If you do an oral glucose tolerance test, you're looking at the fasting blood sugar and you're looking at the postprandial blood glucose. So you can actually see, does this person have a problem with their blood glucose when they wake up in the morning, or are they having problems after they eat? Because what you may find is that somebody has totally normal fasting blood glucose. So if you use that as a screening test and they're negative, but you fail to test them after they eat, you won't capture that they actually have problems metabolizing their foods after they eat. So I like to look at different numbers.
Traditionally, there would be a polyglucose, glucose 1 hour challenge that would be done, around that sort of 24, 26 weeks. And then if that comes back saying high risk, then it goes on to being a GTT, so the full 3-hour fasting ritual. And but if you could, wave a magic wand and just say, this is the optimum thing that we are doing with our pregnant women with testing, what would the test be and when in the pregnancy?
Well, I guess it depends on what you're testing for. So if you're testing for undiagnosed type 1 or type 2 diabetes, then you could absolutely do that hemoglobin A1C and fasting blood glucose. But if we're talking about gestational diabetes in the second or third trimester, then again, you want to do the 1 hour challenge. That if that comes back abnormal, then you send the patient for the 3-hour oral glucose tolerance test. That's the gold standard.
Yeah. So you're happy with that current kind of system?
Yeah, I think that works well. And then there's some practitioners that will even have patients monitor their blood glucose on their own. I've even heard like clinicians that become pregnant say that they sometimes prefer that. So you can always give them block testing to do at home if that's something that they're willing to do.
So interesting. And so from your perspective, what are some of those short-term and the long-term consequences of gestational diabetes, for the mother and the baby, and how do you see that they can be prevented?
Well, I would like to bring up something that you mentioned is that, if you're able to control that blood glucose during pregnancy, a lot of those complications might be non-existent for you. But some of the things that we initially worry about when you develop gestational diabetes is preeclampsia, which is very dangerous. It's actually one of the highest causes of death in the United States, cardiovascular disease, so hypertensive disorders during pregnancy. So we worry about the blood pressure going up with moms with gestational diabetes. Also, increased risk of birth trauma or shoulder dystocia, having a macrosomic infant, and in later life developing type 2 diabetes, because even though this is a pregnancy acquired condition, it does reveal a vulnerability about the mother that she's at risk for type 2 diabetes, because since her pancreatic beta cells are not able to compensate for that natural physiological insulin resistance, we know that there's some type of beta cell dysfunction going on. And so if that is not, addressed during pregnancy and after pregnancy, then she has a lifetime risk of developing type 2 diabetes about 50% or more. And even some of the research is saying in Latin American women, about 60% of them will develop type 2 diabetes within 5 years of that pregnancy, that they had gestational diabetes. With the baby, we're worried again about them being too big, the macrosomia, having to have a surgical birth, neonatal hypoglycemia, so their blood sugars being low when they're born, just because they were exposed to so much hyperglycemia or high blood glucose during pregnancy. Their body compensates for that rise in glucose by making even more insulin. So when they're born, they have a condition called hyperinsulinemia. They're making a lot of insulin, and as a result, that's bringing down their blood glucose, and that can be very dangerous and cause neurological complications and NICU admissions if that is not addressed. And certain medications taken during pregnancy to control gestational diabetes also increases that risk, such as glyburide. So that's something that we look out for. And mothers with gestational diabetes also tend to develop hyperbilirubinemia at higher levels. And then there's some research that says stillbirth is increased, but a caveat to that research is that it also says that as long as the mother is well controlled, there is really no risk of increased stillbirth. So we're talking about gestational diabetes that is uncontrolled, causing the most really severe consequences.
Yeah. And so with the babies, they as you say, they can become macrosomic, which is meaning large for dates, and they've got quite a distinct look to them as well. We would call them cherub looking babies. I mean, babies are born with not much neck anyway, but these guys have nothing. They're like, they're just Buddhas, these little Buddhas, and the big round faces and the no neck, yeah. And so you've got these really sort of giant looking babies in a way that, and as we should call them, the cherub looking. Yeah, but that's because their body their pancreas is being forced to sort of produce these high levels of insulin to cope with that mother's high blood sugar levels. The insulin acts as a growth promoter, right? So that's why we end up with these big babies. And then because you've got this a chubby baby, we can have those increased rates of, as you say, shoulder dystocia, where the head can be born, but then the shoulders get a little bit tight, and that can cause problems. And then also the big thing that we see, of course, is that when women have gestational diabetes, the first thing that's going to be talked about practically is that the idea of waiting for that woman to naturally, spontaneously go into labor is just completely thrown out the bucket. It's gone. No, she's already being told, oh, you're going to be getting induced, at around 38 weeks or whatever it is. And the consequences of inducing a labor rather than the body spontaneously, naturally going into labor is massive. The whole cascade of intervention, and when you take a woman who's it's her first labor and you're inducing her into labor, the chances of her having a lovely, normal vaginal birth are just so low. It ends up as ventouse deliveries, forceps deliveries, C-section deliveries, obstructed labors, failure to progress, fetal distress. All these things happen because of the induction process. Mm-hmm. And then when the woman has gone through these dramatic and traumatic births, her recovery and her headspace and the baby's recovery from it all just automatically will impact breastfeeding. I
Yeah.
just can't not. When you see a baby that's born naturally beautifully and it comes out and they almost look like they're purring, they're just like, oh, happy and content, latch onto the nipple and everything goes right. And then you see a baby who's been delivered, say, by ventouse or forceps, or a baby that's basically in shock after being delivered by crash emergency C-section. These babies are traumatized and they can't latch in the same way. Like they're in their own recovery process. So now the breastfeeding's not working so well. So the mother's not bonding so well. So she's feeling depressed at the whole failure to birth, failure to breastfeed, the whole thing. And you can take it often, you can take it all the way back down. Where did it start? When she got diagnosed with gestational diabetes. That was the beginning of this whole thing that has turned all her dreams and expectations on what she was hoping was going to be into a complete and utter gone to custard sort of situation, isn't it? And it's and we know we can prevent it. So let's talk about the prevention. What are you? I guess you've got the women who are low risk, and what they can do to prevent, and those women who are already got risk factors, which you might want to go over. And so what's your thought? What's your advice on the prevention?
And thank you for saying that. That's just a shame that when you're given a diagnosis, it's almost like you're given this sentence, oh, I have to go into labor induction, I have to have a surgical birth now, and it's just absolutely not true. So women with gestational diabetes do have to learn that different side of what their options are. Just because you have this diagnosis doesn't mean that I can't follow through with the birth plan that I originally had.
Oh, you're so right, especially right those women who have got who have well-controlled diabetes through diet alone. Because if they want well-controlled diabetes through diet alone, they're not on medication. Why are we intervening?
No need to. They can be delivered with expected delivery, just like a woman that does not have gestational diabetes.
Yes,
they can
agree.
follow
All
that
right,
same.
high five you.
Yeah.
You just want to, sometimes when I hear this is going on for women, I just want to pick up their obstetricians and kind of slap them. And I'm sorry to the obstetricians who are listening, but if you're watching this, if you're part of our program, we know you're already, on the same page with us anyway on this. But women don't even realize that for themselves, right? Oftentimes they feel pushed into, like, there's no options.
Right. And there's always an option, especially like you said, you're well controlled. Even with medication, you're well controlled, you still have options to have the birth plan you wanted. So work with an obstetrician or a midwife that respects your wishes. But in terms of preventing gestational diabetes, there's a lot that can be done when you're trying to conceive. And so for women that are trying to conceive, we always say, for 3 to 6 months, you want to try to get your lifestyle in together. You want to get it together in terms of eating healthy, exercising. Usually you want to aim for 150 minutes of physical activity a week, moderate aerobic physical activity. And the types of diets that have been shown to prevent and reduce the risk of gestational diabetes are plant-based diets. And so I know a lot of people and a lot of women now, it's been very popular to go on ketogenic diets or Paleolithic diets that are usually higher in protein and fat and lower in carbohydrates. But we're seeing research that being on those types of diets actually are not providing the micronutrients that are needed for pregnancy. And so even when a woman is on a ketogenic diet and she's replacing vitamins and minerals by using a supplement, that supplement still is not giving her enough folate to prevent neural tube defects. So there have been research studies that showed that women on ketogenic diets before pregnancy trying to lose weight are having babies with neural tube defects because the ketogenic diet is just not sufficient to provide a lot of those vitamin and minerals that usually are in shortfall in pregnancy anyway. So
Right,
eating.
and there's so much, we talk about it a lot all the time here at IMCO with preconception healthcare. And ideally, is seeing a maternity naturopath who's hopefully their specialization, or they have an area of specialization of including maternity, fertility, subfertility, infertility, and having that micronutrition, as you say. And ideally, we would always say 6 to 12 months for the female and 3 to 6 months for the male, because the more we're researching, the more we're realizing that sperm health impacts pregnancy health too, and impacts obviously fetal health. And yeah, so it just, as you say, having that whole preparation time, so let's say ideally say sort of about 6 months of the preconception supplements and lifestyle adjustments, big differences.
Yeah, and it can take a while for some people to make lifestyle changes. It takes time to grow and to change and to make changes in your diet and, incorporate the amount of exercise that you need. So time is of the essence. Like you said, the more time, the better. For women that find themselves at risk during pregnancy and they miss that trying to conceive period, they can still prevent gestational diabetes by adopting those healthy lifestyle behaviors during the first trimester. So if they don't have an exercise plan prior to that, they need to get an exercise plan immediately. And any little you can do to start is good. Every big habit starts with one small step. So even if it was 10 to 15 minutes a day that somebody could start with aerobic exercise, that would help, especially if they do it after meals. That helps to bring down the postprandial blood glucose, anywhere from 20 to 40 milligrams per deciliter. And so
and
just
when you say after meals, within what sort of timeline are you talking after meals?
It could be immediately after if that doesn't bother you. If you want to give your food some time to digest, maybe within 15 or 30 minutes of eating.
Quite soon. Yeah.
Especially with people with gestational diabetes, you already have a diagnosis of diabetes. Postprandial exercise is actually the most efficient because it helps those blood glucose levels drop. So it's a nice addition to, if you're taking medication, this is a nice natural addition to dropping your blood glucose.
Right. And what a simple thing to explain that I don't know that that's well explained to women, that, if you're going to, you're committing to your 150 minutes a week that you're going to, that you're doing. But if you just time it, not too long after you've eaten, you're going to get all these other benefits. Rather than doing it, say, before you're eating. And yeah, a simple change, it makes a big impact. So how has, do you want to explain a little bit more about how gestational diabetes is traditionally getting managed with nutrition? Because obviously what happens, well, it's not obvious if you're unfamiliar with it all, but basically when a woman gets diagnosed with GDM, gestational diabetes mellitus, then sort of the next step is that she's given a glucometer and she starts to monitor her own blood sugars, and the hope is that she'll be able to adjust her food intake, that she'll be able to keep everything within normal range, and for many women that can work very successfully, and for some women, goodness, they can do everything right, and even then it still gets to the point where they're going to need metformin or insulin, and it's even though they've done everything right. But the ideal is that hopefully it can be managed by diet alone.
Yeah, so about the research says about 70 to 85% of women diagnosed with gestational diabetes will be able to be managed with lifestyle modification alone. But then
that's high. That's good. That's promising.
Yeah, it's a really good chance of not having to take any types of medication. But at the same time, it leaves about 30% of women that are going to have to take some type of medication just because everything they do it will not overcome the insulin resistance. And, traditionally, especially with organizations here in the United States, like the American College of Obstetricians and Gynecologists, they've suggested that women are placed on a low carbohydrate diet. So restricting carbohydrates anywhere from 33 to 40%, because one of the misconceptions, even with non-pregnant adults that have diabetes, is that once I have diabetes, I can't eat carbohydrates. And carbohydrates get this really bad rap, because what comes to mind when people think about carbohydrate is that they're thinking about all of the refined processed foods. So they're thinking about the cakes and the donuts and all of the pastas and all of the things that we know aren't really good for us and it will spike your blood glucose, but they rarely think about whole grains and whole grain breads and whole grain pastas and legumes and lentils and fruits and vegetables and foods that are low to moderate on the glycemic index that are really not going to spike blood glucose values. And I'm also an aromatherapist, and I know a lot of your audience is also, you're integrative. And so anybody working with herbal medication or plant-based medication can understand that plants have therapeutic effects. So plants have effects that are anti-inflammatory, that reduce oxidative stress. And so if we're telling people not to take in plants that we know have these therapeutic and medicinal benefits, and we know that is at the root of gestational diabetes and type 2 diabetes is this inflammation and oxidative stress, then you're eliminating that from their treatment plan. And when you replace it with this high protein, high fat diet, we also know that lipotoxicity, a high fat diet, also contributes to insulin resistance. So it's counterproductive. So even though we're taking away the carbohydrates, because in our minds, it just makes sense, your body's not breaking down glucose. Well, let me take away things that elevate your glucose and give you something else without any carbs. It's counterproductive because it's still going to raise their blood glucose levels. Whereas we know that the plants is going to help with that inflammation and oxidative stress. And paradoxically, it does bring down the blood glucose and manage the blood glucose if you're eating whole foods, non-processed carbohydrates. Not carbohydrates that you typically buy at the gas station.
Right. Yeah. And people are like, oh, well, what's refined? Well, that's where something's been done to it.
Yeah.
Right.
Anything not in its natural state, anything that has a label with 20 or 30 things into that product, that is not natural. That is not whole. So anything that's processed and not in its natural state.
I know a couple of my personal favorite food items I've always recommended with women with gestational diabetes is stevia, of course, as a sweetener, because it's got 0 glycemic index. What it really does is it just tricks your taste buds into thinking that something's sweet. So if you're like a person that enjoys a cup of tea that has, a teaspoon of sugar in it, well, just put a teaspoon of stevia in it and you'll still get that feeling of your sweet cup of tea that you like, and it's got 0 sugar. And then the other one is shirataki mushrooms, of course, which, they turn into shirataki noodles and shirataki rice and shirataki pasta and things. And again, it's practically 0 glycemic index because it's not carbs, but you kind of feel like you're eating carbs. So those two are a couple of great cheat items. But what are what's your thoughts on on nutrition? Like, what do you advise women as sort of an overview guideline of what they should be doing? Maybe samples of sort of the meals that you'd say breakfast, lunch, and dinner. What would you like their plate to look like?
Well, it's all going to depend on the client. Some of the research shows, like traditionally for breakfast, a lot of clinicians have told patients not to eat a lot of sugar or a lot of carbs at breakfast, just because they have that early morning rising elevation in their blood glucose with their cortisol levels and all of their adrenaline hormones at its peak. And so a lot of clinicians will say, limit your carbohydrates between 15 to 30 grams of carbs for your breakfast, which is more based on experience than research. The Academy of Nutrition and Dietetics actually showed in a research study that a low glycemic breakfast, even with carbs going up to 60 grams for that typical breakfast, would be appropriate and has shown to manage blood glucose. So their blood glucose of the women that ate those breakfasts, even though they were higher in carbs, still resulted in normal blood sugar. So something high in protein. I don't have gestational diabetes, but one of my go-to for breakfast is a bowl of oatmeal, and I pack it with seeds and nuts because we know those are full of fat and protein, and that's going to slow the absorption of carbohydrates. So adding hemp hearts, chia seeds, flax seeds, maybe a quarter cup of your favorite nuts, walnuts or pecans, and then adding some low to moderate glycemic fruits like berries, blueberries, blackberries, raspberries on top of that, that would probably work well for someone with gestational diabetes, because it's mixed with all those macronutrients that are really going to slow the absorption of carbs. And then you have maybe an avocado toast that you can mash up with some white beans, some navy beans, and spread it over some toast. That would work well as well. Because again, a lot of fat and a lot of protein mixed in with your whole grain carbohydrates. And then for a midday snack, because we don't want women with gestational diabetes having all of their carbs at one meal, your snacks is where you want to probably put your fruits, and you never want to have naked carbs. You want to combine them with a protein and a fat, again, to slow the absorption down of that carbohydrate. So you can have apples or orange or pear, and pair it again with some nuts or a piece of cheese or some Greek yogurt, which tends to be really high in protein. And then for lunch, I like lentils or legumes. You can have maybe a bowl of that with some greens, especially because greens, we know, again, has a lot of nitric oxide, and it's anti-inflammatory. So we want to have mamas eat some greens throughout the day with their meals. And then for dinner, you could substitute, instead of eating regular rice, sometimes you might want to substitute it with some cauliflower rice. And you can have cauliflower rice with some beans, and then you can have some lean protein, whether that's animal-based or plant-based. And half of the plate, usually we ask women to have that to be non-starchy vegetables. So whatever non-starchy vegetables that you like, roasted cauliflower, broccoli, or asparagus, or if you're a salad lover, you can have that plate to be half of greens again, mixed in with some different veggies. So I like to use the plate method a lot. I think it's a good framework. The traditional plate method is that a quarter of your plate is fruit, a quarter of your plate is vegetables, a quarter is your starch, and then the next quarter is your protein. But with gestational diabetes, I like to modify that plate, and I like the plate to be at least half of non-starchy vegetables, because we know that's going to be low glycemic index, and that's not going to spike blood sugars very much. And then the other quarter of the plate can be any type of grain or starch that the client likes, and the other quarter, again, can be plant-based or a lean animal-based protein.
That's a great overview. And as far as sort of starchy and non-starchy vegetables, obviously that's things that people can look up and Google if they're unsure. But as a real kind of generalization, if the vegetable grows below the ground, then it tends to be more starchy. And if it grows above the ground, then it's not so starchy. So you kind of, women can think in terms of that, that sometimes makes things a little easier. Like our wonderful potatoes that grow below the ground and are full of starch. Okay, so what are some of the emerging nutrition models that can be used, in relation to, gestational diabetes, and I guess what sort of research supports those plant-based diets? That was so interesting what you're talking about, the ketogenic diets, and they're starting to see a correlation of that with being slightly higher risk for neural tube defects. And this is the thing, is that the more we research every topic when it comes to maternity particularly, the more we realize that we don't have a clue, and there's more research we need to do. And I think that that's because I've been a research midwife at a university, and I think that we can't, there is this kind of general expectation by the public that the doctors now know everything. And no, we don't. We know this much, and we still need to know this much. And the thing when it comes to maternity is that because so much, let's say over the last 200 years particularly, so much of medical science has been based around the male body, and it's almost like we're only just now starting to go, oh, actually females are really quite different, and this is it's like an area that's been kind of forgotten. Even something as simple as the signs of a pending heart attack have always been based on what the signs are for the male body, but actually the female body has a whole different sort of set of things that are red flags for that. And so we're beginning to appreciate, and certainly when I was at university as a research midwife, as soon as you complete one study, you're going, that one study has produced the need to do another 6 studies. Because it's like, oh no, you're getting these results where you're going, we didn't expect that, we need to do some more research on that. So we are really where there is so much more that medicine needs to learn and understand about the pregnancy journey. And again, that's where, and decades from now, the idea of integrative medicine, of women seeing their allopathic, meaning mainstream modern medicine, their allopathic unwellness maternity specialist, i.e. their obstetrician, is important, but they also need to see their naturopathic wellness maternity clinician, i.e. their medical herbalist type thing, because that not one area knows it all.
Exactly. Yeah, it would be too much for one person, too much for one discipline to know all of the information. So we really have to work as a multidisciplinary team. And plant-based diets have really been on the rise, especially in research. There's been a lot of research in non-pregnant adults that plant-based diets have the ability to reverse diabetes. And so for me, if I'm going to prescribe a nutrition plan for a mom, even if she's not going to go 100% vegan during pregnancy, that might be a big leap for a lot of women to take. I still want her to be on that journey of starting a plant-based diet, primarily consisting of plants. So a lot of the research now, even in pregnancy, shows that the DASH diet, the dietary approaches to stopping hypertension diet, if it's used in pregnancy, helps to control gestational diabetes and improves birth outcomes. Just as we see with those lower carbohydrate diets. Now, lower carbohydrate diets, to an extent, can control a lot of the things that we don't want to see in pregnancy. So to an extent, yes, it can control weight gain. It can control blood glucose values. But what people are not looking at is the long-term results. So there has been a US seminal study showing that women that were on very low carbohydrate diets, and probably that diet didn't have enough calories at the same time, they had children that at 2 to 5 years had a lower intellectual development. Um, and
Wow.
so, yeah, and so we're seeing research that's showing that women that are producing ketones during pregnancy, because the ketogenic diet, the byproduct is that you produce ketones, that might not be safe for the developing fetus. And I've listened to different points of views. I've listened to dietitians that are kind of more in that field where they prefer to prescribe ketogenic, Paleolithic diets. And it's because they're getting those good, immediate, short-term results. But what are the long-term results for children? Is what I'm interested in, because I want to
Gosh,
get you
that's
through the pregnancy, but I
huge.
want you to have a healthy child as well.
Mm.
So we have to think about the long-term implications of low carbohydrate diets. And even with non-pregnant adults, we're starting to see research that is now saying that the ketogenic diet is not healthy, and it could increase the risk of cardiovascular disease. So,
That's a big deal, and it's almost refreshing to hear you say that, because from my perspective as a midwife, and I don't have any science to back this. There's no double-blind trial that's been done, but it's just my observation is we do expect that when a baby's head is crowning, that the body's perineum will have a natural elasticity to it, and different ethnicities and different ages of women, and just there are other things that impact that, but and things like perineal massage beforehand can be very helpful. But what I would have to say is we see a first degree or second degree tear is not a big deal, and we do see that. So that's just that's not uncommon, and heals beautifully, and it's not a big concern. But every so often in my practice, I have seen a perineum that can only be described as shattering. And it's so rare, but it's so dramatic at the time, and it doesn't make sense, because I've seen it in situations where women, they're not 43, they're 23. What's going on? Where's the elasticity in their skin? And I will tell you that the worst perineal shatterings that I've seen were always vegetarian women who were very strict on their diets. Yeah. So, women who were just super, super disciplined, so one of the things that after a baby is born, and that placenta is born, one of the things that was like be my absolute first thing I practically do for that woman is I'll make her a hot chocolatey drink, because I know she's low on sugar. And I found a real correlation between making sure women have a really good hit of sugar after the marathon of that labor, and that stopping her fainting later, or because they last on adrenaline for a little while, but then when you go and have a shower, an hour later or sometimes, suddenly she's fainted in the shower. And I found that so long as I would give them this really good hit of a hot chocolatey drink, which, let's face it, you deserve after giving birth to a baby, then they get into a better place. But these would be the sort of women who would decline a hot chocolatey drink after giving birth, because they're that disciplined on their diet.
Yeah.
Right. And so I don't know, it's so interesting. As I say, I don't know of any studies that have been done on it, but yeah, that really low fat, restrictive vegetarian diet is not helpful, in my opinion, on perineums either. So I hadn't heard
And
what
I
you're
think
talking about
depends.
relating to childhood IQ, that's a big deal. We need all those great facts in the brain.
And I think, it depends on how well the person's nutrition literacy as well, because sometimes people will start so I'll just start off by saying the Academy of Nutrition and Dietetics says, vegetarian diets are suitable for any stage of the reproductive stage. So trying to conceive and throughout pregnancy. But I think what happens sometimes is that people may not know the foods and the amount of protein that they need on those types of diets and where to get the protein. And so it might not be a healthy vegetarian diet. Because we know that a lot of those plant-based diets are helping women with gestational diabetes. It does have to be a well-planned out vegetarian diet. So I think if a woman is pursuing that type of meal plan or dietary plan during pregnancy, she needs to see a dietitian.
Right.
Because they
Get
need
that
to
really
make sure
good knowledge.
yeah, you really have to be careful, because if you're on that type of diet, you really need to know how much protein you need in a day. You need about 71 to 100 grams during pregnancy. And so if you're just eating non-starchy vegetables and you're not getting enough protein from your plant-based sources, you're going to have a problem. And so I've seen in research with both low carbohydrate diets and very high plant-based diets that sometimes the result is a low birth weight baby because the diet is not sufficient. So the person really has to know how to eat well on those types of diets. And so if it's not somebody that has been doing it for a long time, they may not have that knowledge, and they may need a registered dietitian to help them during pregnancy with that.
Right. And yeah, it's having that well-rounded balance of knowledge of what you're doing. So we're getting close to time here to conclude, but what about, I guess that plant-based diet must also support, we know it would support blood glucose and gut microbiome, but there would be, I guess, other nutritional supplements, that would help modify blood glucose. So do you want to sort of go through a little bit of that as we come close to a conclusion?
Yeah, so there's a couple of different supplements that's listed in the research. One of them is omega-3 fatty acids that was talked about. Unfortunately, the research didn't support it for gestational diabetes, but they said it was good for other pregnancy outcomes, such as premature birth and low birth weight babies. So women that are at risk for premature birth, you might want to put them on omega-3 fatty acid supplement because that did help. But the research,
you want to be on that anyway in pregnancy. You want to be on there even when you're not pregnant.
Oh yeah, I'm on it every day.
Yeah.
So yeah, that's one of my favorite supplements, just because omega-3 fatty acids, again, anti-inflammatory, good for cardiovascular health. And so it's definitely invaluable. The other supplements that were mentioned in the research that could modify blood glucose was vitamin D. A lot of women are low in vitamin D, and we know it's associated with diabetes and preeclampsia and other hypertensive disorders. So vitamin D is very essential during pregnancy and with metabolizing blood glucose. Also, probiotics could be helpful. The research there has been a little conflicting, but more promising than not. So we know, again, women with gestational diabetes or weight management disorders, the obesity, tend to have an altered microbiome, meaning they don't have enough microbes or bugs within their gut that can help them metabolize and break down blood glucose. And so taking a supplement has been shown to help some people. And then the other supplement that was found to be useful was magnesium. Magnesium helps, again, with metabolizing blood glucose. Taking that at bedtime is something that you can recommend to your clients, especially because it helps with sleep. It might help them with the muscle cramps that a lot of women get during pregnancy. along with being hydrated and maybe taking some electrolytes, that might as well help with bringing down their blood glucose. And one of the last supplements that I saw was myoinositol, and that's supposed to be very good for gestational diabetes and reducing insulin resistance. So if you're deficient,
interesting. Do you want to
yeah,
tell us a little bit more about that?
the myoinositol. Yeah, so that's a polyol. It's derived from plants and can also be derived from animals. And what they found is that taking that actually reduces the insulin resistance, so it will help with fasting blood sugars and postprandial blood glucose levels. When they compared women taking it and with a placebo group, they found a definite significant reduction in insulin resistance taking that. And the amount that you would need to take, or that's taken routinely in clinical practice, is about 2 grams a day, twice a day, I believe. But in some research studies, they've gone up to 4 grams a day. And that seemed to be safe.
Wow, that is very interesting. If we just go back to the omega-3, because obviously there's a lot around of supplements, a lot of sort of almost variety of choice within that. If you've got a woman in a situation who has got very little spare income to spend on that, is there like what would be your most sort of, say, your most basic option on that you would suggest? Or if somebody has, you know, a more unlimited funds, or, you know, not unlimited, but, you know, they could be more generous on the quality of their supplements, and you know, have you got a little bit of commentary on that? Only because there's just so much around, it's almost hard to choose what to get.
Yeah, definitely. And then you want to be careful with the quality, because some of them could be oxidized and you may not be getting the amount of omega-3, the EPA and the DHA that you want.
Yes.
So, you know, fish in general, there is a restriction during pregnancy just because there can be toxins in the fish, especially high mercury fish. So you want to take that into account when
and
you're
I'll just interject, those high mercury fish tend to be those fish that are large because they've lived a long time. Yeah, so, you know, your great big huge tuna will have a whole lot more mercury accumulated in its body over time than, say, little tiny krill. So yeah, anyway, I just thought I'd throw that one in there, but yeah.
Yeah, so I mean, I've heard of krill oil, but I know for me, for myself personally, and for patients, I do like a high quality fish oil. So Nordic Naturals tend to be a higher quality fish oil. If somebody didn't want to take per se fish oil from a fish, there are algae omega-3 fatty acid supplements that you can take. So there's actually this company called Needed. It's a new prenatal company, and I believe their products are pretty high quality. I've evaluated the numbers on their prenatal vitamins and looked through all of their products. And I would say that I would recommend their omega-3 fatty acid supplement, and it's made from algae. So it's actually not made from fish. And so that's another thing to consider too. You want to look
linseed,
linseed?
Flaxseed or linseed.
Oh yeah. So flaxseed are natural ways to get omega-3 fatty acids, flaxseed. You can do hemp hearts. You can do chia seeds. So all of the seeds that I include in my breakfast on a daily basis, in my oatmeal on a daily basis, those are high in omega-3 fatty acids. Nuts, walnuts, very high in omega-3 fatty acids. So those are where you're going to get a more economical way to get your omega-3 fatty acid supplements, because sometimes it could be a little bit pricey. So if you're looking to cut down on costs, get it from foods like that, and eating 6 ounces, at least 6 ounces of fish a week is going to get you your omega-3 fatty acids as well. Eating some fatty fish, salmon, is going to get you your omega-3s that you need if you don't want to necessarily spend more money on a supplement.
Right.
But if you do spend money on a supplement, make sure the supplement is third-party tested, because again, supplements don't tend to be approved, especially here in the United States by the FDA. So you don't know the quality, but there are third-party organizations that will evaluate supplements and say if this is a good quality substance.
Yeah, and very much
supplement.
going to your local health shop and asking the naturopath who's working behind the counter, you know, what's the best value, best quality supplements that I can get? Because one of the things that we do see in anything to do with prenatal supplements is that often the most well-known brands are not necessarily the best value and not necessarily the best quality. The reason that they're the most well-known is simply because they've got the biggest advertising budget. And that typically is a pharmaceutical company who are going, oh, you know, like, let's get that market as well, you know. So they're already making these medical drugs, but they're like, oh, let's tap into the supplement market. And yeah, so don't, I guess I'd say, don't get sucked in by the fact that, you know, something's well advertised as a prenatal supplement or multi, particularly. Yeah, go see your naturopath and say, what is actually the best ones that I should be taking?
Absolutely, yeah. I remember some years, it's been some years ago now, and I won't say the name of the drug here in the United States, but there's a drug that they started marketing, which is pretty much omega-3 fatty acids, and it became prescription. And, you know, me and my husband were watching that commercial together, and I said, that's just omega-3. You can get that over the counter. You don't need a prescription and then authorization, because the prescription is so high to pay for, because now it's being marketed and now it has a brand name. And all of these things, really, you can get them on your own. So like you said, the marketing budget makes a big difference.
Yeah. And I'm sure on the advert, it would have been, you know, coming across as miraculous and new
Right.
and innovative. And you're like, no, it's been around a long time.
A long time. And you can
Well,
get
look,
it in
it's
your
just been so great having you here today. And Michelle, is there anything you want to conclude with and finish off with? Anything more that you'd like to add?
Oh, well, thank you again for having me.
Thank you for taking the time to impart your knowledge. We really appreciate it.
Oh, you're welcome. And I'm just so excited about this topic, and for your audience, you know, who are clinicians and non-clinicians, really taking on this. And, you know, to all the mothers that are going through this right now, there is hope. You know, like we said, it is very scary to receive a diagnosis, especially if you've been healthy all your life and you've never had a medical condition. It can be really surprising and overwhelming, but it's something that is very manageable. And the health behaviors that you adopt during this time period really are going to affect you and your baby lifelong to prevent type 2 diabetes, which is on the rise just in the general population. And so while it may seem frightening, there's also hope on the other end. And there's also so much options out there to treat gestational diabetes, and so much people willing to help, you know. So don't think you just go to your doctor. There's registered dietitians, there's nurse practitioners, there's clinical nurse midwives, and maybe having a doula or childbirth educator, or seeking out mental health services, if that's necessary. It's there for you. And so there's this whole big team ready to help you, and there is hope. So that's the last thoughts I want to leave with the audience. It's definitely a manageable condition.
Thank you so much, Michelle. And thank you to those of you who are live today. We always appreciate our live audience, and we know that a lot of you will be watching this later down the track. And so just want to wish you all a wonderful rest of your week, and In fact, this is the last webinar that we're doing live for about a month, 3 or 4 weeks, as I'm disappearing myself and having a little wee break. But I just want to wish everybody a wonderful rest of their week, as I say, and thank you so much, Michelle. Oh, just before we conclude, last thing, would you like to just go over your contact information if anybody would like to connect with you on the topic?
Oh yeah, absolutely. So you can reach me via email at sugarbumpcoach.com. You can also reach me on socials. I have a LinkedIn, I have Facebook and Pinterest, and my handle on all of those are Sugar Bump Coach as well. So yeah, please send me your questions if you want to continue the conversation. I'm happy to do that.
Thank you so much, Michelle, and thank you to everybody live here today. As I say, wishing you a wonderful rest of your week and rest of your day. Okay, bye, Michelle. Bye, everybody.
Take care.